All right. Well, let's get ready and get started with our 3:30 presentation. Boom, boom. Hopefully everybody had a chance to get stretched, or if this is your first presentation today, you are ready to go. So just a quick reminder before we get started with our next presentation. Again, my name is Sean. I'm one of the conference committee members, and welcome to the 2021 conference. For this is our third session of Friday. For those who were attending the first two sessions, or if you didn't get a chance to and want to see it, there are recordings of those which we will make available on our YouTube page or site before too long. If you are sitting there with multiple folks at your home agency, we suggest that you do a training roster for the day for each session. Just that probably be the best way to keep track of who's attending there versus relying on us to remember to get you down. For those who did register and signed in, about an hour after the end of the session, GoToWebinar automatically sends you a certificate of completion. If for some reason you really want a certificate of completion and weren't the person registered, just email us, let us know, and we'll send you one out. On that certificate of attendance, or also in the description of each course, it shows the state of EMS, or state of Oregon EMS category that this applies to. If you're going to use it for registry or national registry or other states, I'm sure you can figure out it applies within your own site. Feel free as we go through, please put questions in the question box or in the chat. And if it's something that needs to be answered right now, we'll interrupt the presenter and ask him the question. If not, we'll ask the questions at the end. After it starts, you can press the little red arrow and it'll get that box out of your way. If you don't want to see it, if you want to ask questions, push it back open to ask us any questions you might have. This is the last session for Friday. Just make sure if you want to register for the Saturday sessions and haven't already done so, you can go to our website and do so. If you're having audio issues, you probably can't hear me. So whatever I say right now won't really matter. However, if you're having occasional audio issues or somebody that is, we did put a link and we'll put it back in there again that shows the troubleshooting people can go through if their audio is not working. So with that being said, I am going to turn it over to Dr. Buchholz. He is going to take us through the next hour presentation here.
Sean, can you hear me okay?
I can hear you, yes.
Perfect. Well, I would like to thank you for having me as a presenter to talk about pediatrics. And my topic will be preventing long-term trauma in pediatrics. And I have a few little slides up there of patients that I've seen over the last decade and a half. The first child on the left had a piece of rebar thrown at him and it went through his upper lip and lodged at the base of his tongue. And the other one is a typical angulated fracture that we often see. Here's my title slide. I work in the pediatric critical care department as well as pediatric emergency medicine at Randall Children's here in Portland. And I'm clinical medical director for outreach and advocacy, which really means I go throughout Oregon and Southwest Washington to talk to emergency departments as well as EMS agencies for pediatric emergency and critical care. And I do this because our outcomes in the pediatric ICU really depend on EMS and the first interaction with children. Been around the world, well, not the world, really, just the West Coast, Washington and Arizona and Colorado. And I mention these because these are areas where I've seen all the way from academic emergency departments to community emergency departments, and a variety of different experiences. And what I've noticed over the years is some children are very afraid, others are not. But most importantly is most and the overwhelmingly majority of EMS call did not require this book of PALS. They required they weren't ICU patients, but the early interactions from EMS really made a huge difference in the second and third time we would see patients or these children. This is my current environment here at the Children's Hospital. A lot of kid-friendly artwork, and it's really fun for the kids. Where I work, we have level 1 pediatric trauma, pediatric surgery. I do my partner's ECMO, where they're 24 hours a day. But I also have the opportunity to work up at Salmon Creek in the emergency department. And I've been doing both for the past 15 years. And it's really enjoyable to see children who are critically ill on one day, and then the next week return to the emergency department, for which we see children that are not critically ill but require the same level of care. And why I chose this topic, some of it has to do with COVID, because with the COVID epidemic, we've gone from masks to N95 to PAPRs to respirators. And here's a view from what a child may look and see when they're lying down. And there may be 3 or 4 of us. And these barriers are absolutely necessary for our safety. But I did want to put it in perspective for what a child sees, for which they may already be scared and frightened. And many of these will have stories about not only my own childhood in EMS, but also my family's, for which we've used the medical services for a variety of illnesses, I guess. The first I remember was when I accidentally ran my finger through a sprocket in the chain and nearly cut off the tip of my finger in EMS at that time. Second time was when I was running during middle school and ran through a field and ran through a bunch of barbed wire that got caught on my leg. And I still remember the EMS folks putting me in the stretcher and in the ambulance and going off to the emergency department with this barbed wire stuck in my leg. I think I was about 13. More recently, the reach and treat up at Mount Hood. But we all have stories, and children remember these stories for a lifetime. And if anything to take home is, we know from our own stories that children can be traumatized, both very bad, but they can also have very good outcomes. And what I would like to talk about is EMS friendly techniques, how we can improve these interactions with children, because we know that PTSD and long-term mental and behavioral challenges can be started from early interactions. But also what could have made them better, and how children are different than adults. And from a child's perspective, the experience is tremendously different. I've spent many years discussing airway, breathing, circulation, the physiology, and I think I've spent about 1% of the time discussing how a child perceives different interactions than an adult. A child doesn't have any experience. They have no idea what's going on. Much different understandings. And as you've known from your own children or observation, a scrape on a leg is a life-threatening problem to a child. However, abdominal catastrophes and abdominal trauma may not resonate as high as just merely a scrape. And we all know that a Band-Aid on the trivial scrape can provide a lifetime of help. Immediately aware, just for example, when we say an IV won't hurt and it will cause pain control later, they may perceive that as punishment. Children have much different expression of pain. We did a little trial and we worked in the intensive care unit using food, starting feeds earlier, and we actually tremendously decreased our amount of narcotics and sedation we had to use. Many of these will be stories from the ICU, but many of them can be also used in the pre-hospital as well as in the emergency department, using those little toot sweets. Really helpful. Hot, thirsty, hungry. We've all seen that children, whenever they have these type of feelings, uh, expressions of pain, they want to move. They want to run from scary things. That's their first interaction. We've had a number of children who needed significant sedation, but it's just because they want to move, and they're scared. And what we do know is post-traumatic stress disorder in pediatrics can be, some studies 15.9%, so right around 15, 16%. Some are high as 75%. In my anecdotal experience, a bad outcome absolutely can be very high. Good outcomes, and children do recover very well, but they can have long-acting or long-lasting PTSD from some of these experiences. And I've been on EMS, have worked with our AMR folks here in Portland, have talked to them and given talks before, and I know that it is challenging out there in the field. Fully understand. And that's where I look at what small things we can do to help children. I did put two of my favorite stars over here on the left-hand side. If anyone can tell me from what age, what decade they were from. I can't hear anyone, but I sure somebody said 1972 to 1977, squad 51. What's that, John and Gage, I believe. It sort of got me into the EMS, and I love it. But it was these small things of how to act. And one small thing is using a single provider. Minimize intimidating gear. If we can, take off our protective gear to approach a child slowly and very less excitement. I've had a number of children who have tremendous injuries, and parents rush in, and the parents are amped up. And I know it's important from an EMS and provider standpoint that we bring it down. And EMS and paramedics and staff are very good at doing this. Looking at a child at eye level, here's a little girl that she actually drowned, had CPR, recovered, but always coming down to their level. Calm voice. On the gentle touch, some studies have said touch is good. I would only do that if a child initiates it or if they want the touch. Back when I started in emergency medicine and critical care almost 20 years ago, this was super common, this papoose board. And I'm sure folks remember it. I'm sure if you are in it, you remember it. Nowadays, thank goodness, in general, the papoose board has gone away to actually having a mother, father, or parent actually help hold the child. And I've seen and have numerous videos of suturing where a parent is holding the child comfortably. Oftentimes it is augmented with a smidgen of intranasal Versed, which can really help produce a good experience for the child. So that's one recommendation, is using a parent to help restrain a child. Definitely avoid papoose boards. And I've given a talk on even on backboards, using and minimizing the use of backboards for pediatric patients. Communication, telling them you're there to help. Very simple information about their injuries. By all means, don't say the time, 1 minute, 10 minutes. They have no concept of time. Uh, and I really like the child in control. Have the child make decisions. Do you want this or this? Do you want to walk to the ambulance? Do you want to be carried to the ambulance? Do you want this type of Band-Aid or this type of Band-Aid? Active contributions, the Band-Aids, rolling tape. There's a story from one of my Lifelike colleagues, and it was a child who was screaming, thought to be in severe pain, about ready to be transported in the helicopter. And when he arrived, the kid was being held down, very, very scared. And what he asked is, would you like to go and ride in a helicopter? And the little kid said yes. And he said, well, you have to wear a seatbelt, just like you have to wear a seatbelt in your car. And that really attenuated the situation and made the child much more comfortable. Restraining, I do know that restraining sometimes is necessary. If we can avoid it, avoid if possible. Really like to minimize papooses, backboards, if possible. This is a little picture of a dad giving his son a little toot sweet, and after I had sutured up his head. Distraction, positive reinforcement. Soft toys, something child friendly. I know the ambulance, it's for all ages from age 1 up to age 110. But if there is something that a child can relate to in the EMS rig, even at the time you see the child, and I've seen so many children who will have a soft toy or something, and it really means a lot. It's these small things that are done beforehand. We see it in the ER, and then we see it when the child is hospitalized as well, is if they have something, they carry it with them through their entire hospitalization. Lighted toys are super helpful, a couple bucks. And one thing that's really nice, movies and distraction therapy. I'll be honest, this SpongeBob character, crazy looking person, I have reduced more arms and sutured more heads with a child watching SpongeBob than I think with just about every other movie out there. As well as stickers and medals. If you have just some stickers with you and you give them when you transport, that's a huge thing for these children. So some of these children are scared, some are not. I just did want to step back because I use my own children in many of my presentations. Some children are just amped up to hear, some are pretty chill to hear, and some are so relaxed you can do anything to them and nothing will ever happen. But the one with the tears, for some reason, had a bad reaction. So whenever has to get a shot or has to do anything, really expresses emotions. And we know that every child is different. And that's the key. And that's the real hard part, is when we transport and have EMS for a patient, is adapting our interactions to the child. And that makes it incredibly difficult. And the type of EMS and injuries I see in the ICU are a small part, in the emergency department are a larger part, but the type of injuries and illnesses in children for EMS is ginormous. Luckily, most commonly, they don't require PALS, but there is the vast majority of seizures, breathing fast, worried well. There's also some children that are seen and not transported. But on the left are types of patients that I see, And on the right are types of patients that are seen in the emergency department. And if you put all of these together, that's the type of patients that can be seen by EMS, which may only transport 10 to 15% of their calls are pediatrics, and very few are critically ill. But many of them will need treatment. And the great thing is our mortality is less than 2%. We have done very well with our airway, breathing, circulation treatments. Early interventions have been incredible. We're using cuffed ET tubes in children. We may be bagging them instead of intubating them. We'll have early fluid resuscitation. We'll have IOs. We won't place Foleys. We have less iatrogenic causes, improved equipment, and improved understanding of diseases. And one thing that's so important is we're improving these things because we are getting involved. This is a letter on the right supporting helmet law nearly 20 years ago in Spokane, Washington. And it's that involvement that has really improved the overall care of children. And the metrics that we measure, even EMS, as well as through the hospital, time on scene, intubation success, different protocols, policies, trainings. Even in the hospital, we measure these metrics. But one metric that we don't measure is the child metric, is have a child tell us about your stay. How was the EMS? How was the emergency department? What did you dislike? What could we do better? How did we communicate with you? We always ask the parents, but rarely do we ever ask the actual child themselves. And here's a view, another view from EMS, not EMS, from the emergency department or the intensive care unit. And it's a super scary place. From Life Flight, here's a view of our ambulance, as well as the helicopter. I wish I could have them painted bright colors and have cartoons on the inside of every ambulance and every helicopter. I think it would help with both children and adults. More to follow. But why is this important? It's important because there's long-term consequences. There's mental and behavioral challenges, less favorable outcomes, increasing costs, and there's been much more research into these adverse childhood experiences. And that's my goal talking to groups, is to not only treat our own, say 30 to 60 minutes, but treating the next 12 hours, 2 days, and looking towards middle school, high school, and onward. I would like to introduce the topic of ACEs, and that's adverse childhood experiences. And it's been around for a while, but it's really gained traction as we've learned that different types of adverse experiences early on in childhood can affect children later and can adversely affect adults. And we know that they're very common. 40% have at least one. And very few people ask, even pediatricians rarely ask, did something happen in the past that is causing what we're currently seeing? Because unless we address that, then it's really hard to address the current issues. But if we prevent that, then it can be very helpful. And PTSD after pediatric EMS experience, anywhere from 16 to 75%. And we do know children have worse outcomes if they have these early adverse experiences as an adult. Regardless of other social determinants of health, these can affect cardiac disease, cancer, diabetes, obesity, poor health. And I know we are only one small part of this scenario, but it's one little part that maybe we can make a little difference. Children are unique because if I look under age 2, they seem not to have as severe memories. Older children have much more memories and adverse outcomes, and it has to do with their development. And exposure can be permanent. And if folks do have more questions, is the CDC has a really nice part on adverse childhood experiences. And as again, there's also another topic called post-intensive care syndrome. And we know that if you survive the intensive care unit, you are not right for a while. And you can have persistent impairments, physical, psychological, cognitive, social functioning, and those take time to get better. The good news with children is they recover. They can recover and they can come back just like they were before. And there at the bottom is just some of these intensive care experiences, developmental milestones, academic achievements, and social interactions. It can really change. And I'll be honest, in the ICU, there are very few studies looking at ICU outcomes and survivors long-term. The ones that have looked at this type of syndrome and long-term issues that continue. And here's a couple more pictures of children who had just horrible ordeals. The one on the left, he was caught in the waterfalls up in southern Washington, drowned, was pulled out, survived with CPR. And the other kiddo on the right, I treated as well, who fell off a tractor and unfortunately was run over. Both had very good outcomes. More on the post-intensive care syndrome. I put this in because COVID, it's not only the COVID deaths that are tremendously important, but also COVID survivors surviving the ICU. Many of these folks will have long-term issues that you may see on the EMS side from adults. Not only just muscle wasting, organ damage, PTSD, mental and behavioral issues long-term. More on post-intensive care syndrome. I like it because it really shows long-term many of the issues that are ongoing, and treating of the child's heart failure, lung failure, kidney failure. Some of this is actually the easiest part. It's the long-term issues that can really affect a child. Mortality, as I mentioned, less than 2%. Morbidity, we're seeing an increase with mental, cognitive, and physical health long-term. I think it's because we're looking at it more. Long-term issues and mental health. And we've seen it in the emergency department, and I'm sure you've seen it through EMS, is mental health and behavioral health is skyrocketing in severity and number of calls. For our post-intensive care children, many of these will have long-term behavioral health impairments. PTSD, cognitive function decreases, but all is not bad. And we've seen it from EMS, we've seen it in the emergency department and the ICU. Children are the most resilient of creatures that I know of. They can undergo absolutely devastating injuries, both physical, mental, and emotional. and they can bounce back. A good study demonstrated 77% improve over time. And children can recover quite nicely. And so I think that's one reason I really love pediatrics is children can recover. And my goal is to try to minimize early childhood adverse experiences. So one topic that has come up is sedation. And I won't go through all the things we look at in the hospital, but it's the choice of sedation. And sedation is super important because in the past we used to give Ativan and Versed, but actually we now know that these increase your chance and likelihood of delirium, which can cause longer term issues. So I did a little study, not really a study, but I talked to my colleagues and I asked some of these patients who undergo lots of procedures and sedation, tell me a little bit about them. So I talked to my oncology colleagues and I interviewed a psychologist and I wanted to know, how do these children do long term? And what she said was, yes, PTSD is very common. For example, just accessing the port, that painful procedure. But what they also said was delirium and the lack of control really adversely affects the child. And Dr. Kabur talks with all of the oncology children, but having a child not be in control really affects them for the long term. Delirium is super important because whenever you are delirious, you're not in control. And that is a long-term, can be a long-term issue. And even in the ICU and in the emergency department, we're using far less sedation than we need to. I know that there are times during transport we need to have somebody sedated. We need to sedate them for their own safety. But many times other mechanisms can work where a child can still retain control and minimize the use of sedation. Delirium, we see it with mortality, length of stay, complications. One of the most common would be if a child needs multiple doses of Ativan en route for whatever reason. We'll see delirium. Benzodiazepines. We are lucky in the hospital. We have other drugs besides benzos that I would ask from the EMS perspective if there's other medications that can be used or other techniques or other doses. Ventilator delirium. So then I asked, and a study is if a child was on a ventilator, would you like to be awake? And these are children that were on a ventilator. What would? To be awake or not on a ventilator. And they interviewed about 18 patients and they preferred to be awake. These were children that were actually more awake than not. Many of them were bored. Family and music helped. Just another story, I was on a airlines and I've always used those cheap earbuds, the cheapy ones. But then my wife gave me these noise canceling ones that she's been using. And it was great. It canceled out all the outside noise. I got to watch my movie. Everything was perfect. So I talked to my colleagues in EMS if that would be possible. Could we use some sort of noise canceling device or even play music for a child en route? And there's a very high degree of frustration. And we are keeping patients much more awake. On the ventilator, they're often awake and comfortable. Here's a couple of very awake patients. And one thing that we're doing is keeping the brain occupied. So from the get-go in the emergency department is keeping their brain busy. And that's doing something, either with child life or even actually doing their homework. So I always have a child bring in their homework and get going on it as soon as possible, because we know that if you keep the brain occupied, then everything else seems to do much better. More about delirium and just being in control, giving children the choice. And my goal is a cross silo and team approach, and it's combining EMS to the emergency department, to families, to the inpatient team. All have the same goal, is to decrease delirium and improve control in a child, because we see it months and years down the road. And I will say I am going to be a little bit early, but I did want to acknowledge that there is a problem after intensive care in EMS, and it's across all hospitals and providers. It's out there, it's a problem, and we are looking at the causes and solutions. So there is a lot of research into, as I mentioned before, the airway, breathing, circulation, techniques. But we need to look at what are we doing now to prevent long-term behavioral health and these PTSD issues for children. And it's going to take time, but it's also well known that if we make teeny tiny changes in our EMS departments, it can make a huge difference for a child. A very small outcome or very small technique, such as a sticker, metal, different types of interactions with a child, can go a tremendous way to having a better experience, which produces actually a better outcome long term. Our take-home points: long-term effects after critical illness are very, very common. And I see them. I see them post-EMS. And I can't thank you enough for how much you do on the front lines, because it's so very important. But if we can, try to minimize sedation and restraints and empower the child to make decisions. Work with them. And it's amazing what you will see, not only that time, but future times. These effects that we see in kids can worsen over time. You're very important in a child's outlook on life. I don't think we really know from a provider standpoint how important we are, but you can actually shape that entire child's future towards all healthcare with that one interaction. Small, very inexpensive, subtle changes, dramatic improvements in our interaction with children. I completely appreciate all the work that is done on the front lines outside of the hospital. I would love to be outside if I can even more, because that's where the real changes happen. EMS, early diagnosis of sepsis, heart failure, child abuse are so important to what we see in the hospital. And this is my take home, is I want all the providers who are watching to either add a comment to the presentation, hopefully good, or send it directly to me, asking the one question: how do I create a child-friendly EMS environment? I want to know what's going on, and I want to share that information with every single person in the conference so that we can make just small changes. And I will send the conference organizer, Sean, the results, and he will send them out to everyone. I will have a list of just what's being done in from my colleagues. And that, my friends and colleagues, is my presentation. And I hope it's helpful. I really appreciate all the work that is done. And if we can make small differences early on, we can make a huge difference in the future. Sean, I would like to open it up for questions.
Yeah, waiting for some questions. Just back to one of your very first slides, just for your information, we actually had Randy Mantooth, who played Johnny Gage, out here as a speaker our second year in the conference. So everyone, I think, agrees with you that Johnny and Roy were definitely a big influence TV-wise for a lot of us, and he was a pretty cool guy.
You know, he was, and I watched that like every day after school for years when I was that 7 to 8 year old kid.
There's some comments, I guess, more than questions. Some people out here, talk to them, but be fair. 99% of our patients are over 50. That's true. One talked about putting SpongeBob stickers on the ceiling of the ambulance. And I think that works for everybody, not just the kids. I think everybody would like that.
You know, Sean, that's actually a very good point. I talked, is it better to have an adult ambulance for kids or a kid ambulance for an adult? And
Yep.
we have many happier adults in a kid-friendly environment. So yes, put SpongeBob and just see how it works.
So here's a question. So instead of benzos, what would you suggest be used for, I'm guessing, for sedation in general for kids?
And that's, what else do you have available?
So I don't know for everyone, but it would be narcotics, benzos, and then some agencies might have nitrous. Probably be your most common.
Yeah. And intranasal fentanyl, of course, for pain, but can also be used for sedation. Benzos are a mixed blessing because, especially in toddlers, they may have an adverse effect with benzos, which is very common. So unfortunately, I may not have a good answer to the alternative aside from saying that they often don't work, and they may not provide what you're looking for. We've used nitrous, we've used fentanyl, we've used toot sweets, we've used behavioral therapies, we've used nothing, we've used a parent. So I know it's not a great answer, but I will look into it more. How about that?
What about would ketamine for kids? Any better, worse?
We've used it. We use it on LifeFlight as one of our go-to sedation agents, and it works very effectively. You can use it to augment fentanyl, and we do use that for our sedation. So yes, ketamine would be effective.
Okay. Another question, I guess, to the end of it. Do you think it's more important that the parents ride in the back with the patient, even if they may be a more critical patient, they might get in the way, or just have them sit up front? How critical do you think it is to have the parent where the child can see them during a critical call?
Well, I think we have parents with the child if they are. There's two aspects. There's the one that if a child is awake, having a parent close is priceless. And then second, if a child is unconscious or asleep, treating the parent and having the parent close to the child is priceless. We have had success with parents knowing bounds and not getting in the way. And so I would always advocate, and even in the most critical of patients, have the parents close to the child for either the parents' mental health or the child's.
Some others, just some comments on here more than questions. People talk about different apps they have on their phones. I know for my ambulance, we carry iPads, and we've put some child games on there and videos for the kids to something to hold on to. Back to, I think your point was distraction works with kids.
Yes, and how does that work?
Thankfully we don't get a lot of kids, but it seems to help a lot. I think your point, one medic was telling me it's been a few months, but it completely eliminated any need for pain management for an obviously fractured arm.
Yeah, it's truly amazing.
Any other questions people want to type in here before we move on? Yeah, ketamine was the most popular comment there, Doc, was the ketamine question. There was 3 or 4 people put that one in there.
And ketamine has a couple benefits as well. It's less hemodynamically unstable. It won't affect your hemodynamics as much as benzos. And it can have pain as well as sedation. So it can do both.
How about one person putting, how about Benadryl? Maybe some IM Benadryl.
Less, it can produce sleepiness, but Benadryl is another one. That is the second drug that causes an increased risk of delirium. So we are using much less Benadryl than we used to for sedation. So I would say Benadryl is also right up there with benzos. I'm sorry.
It's okay.
I'm sorry.
Some folks talking about, just, the calming techniques like we would do with, other anxious patients using, calming and breathing, that one-on-one eye contact with kids. Any tricks or advice for calming parents down in the case where they're more upset than the kid and winding the kid up?
And that's always challenging. What I've said to just about every parent that comes in is to tell them, I will take very good care of your child. And to reinforce that you are 100% invested in their child, you will take very good care of their child, and to reassure them. And that often will have them come down and trust you so that you can do your job well. I think that's the most important, is even with the most horrible of injuries that we see, is just to reassure them that I will take care of your child.
Let's see what else we got in here.
And yes, you cannot give the benzos to the parents. I've had some folks ask that.
Yeah, I thought I was gonna put that out there. I was gonna hold that one back. Maybe just benzo the parent.
I know, 5 of value to the parents.
Yep. Yeah, we don't lie to the patients. One, I'll just ask that thought I had. It's always been a big one to me. Tips or tricks, or how do you deal with a kid who, let's say, a severe upper respiratory that you're wanting to keep calm? Any further inflammation can be a bad thing. How aggressive do you get with, should we get with medications for that versus letting them calm down before they further create airway issues?
That's a good question, because further sedation can worsen their respiratory, can disguise it. So I do know that we have sedated children who are just plain scared because of their croup. And if you sedate them a little, it takes the edge off and they breathe more comfortably. So I will say much of it will be experience. I do like to use it as little as possible, but if needed, start with the smallest dose and work up. So instead of for example, a 20 kilogram child, the dose of Versed is 0.1, maybe start with 0.5. I'm sorry, instead of 0.1 per kilo, so that would be 2 milligrams would be the normal dose, start with 0.5 milligrams and titrate up instead of giving a full dose right away.
When we talk, a lot of folks were talking about being honest with kids. How honest should we be? Is that vary by age, or how honest would you want to be with kids about painful procedures or outcomes and such?
I think it's important at all ages. If it's gonna hurt or it's gonna sting, tell them. because if you say it's not going to hurt, then, and it does hurt, you've lost trust. So it'll be important to tell them it will, tell them exactly what will happen, but then tell them that the pain will go away.
All right, any other questions? Lots of comments coming up on here, but any other questions you have for the doc?
Are children tracked?
How long are children tracked post-hospital stay? I guess I would ask for clarification. Tracked for what specifically? Because I would suspect, if a child comes and sees you, doc, or gets admitted to the PICU or NICU, they're going to be tracked by their own pediatrician afterwards. So how long are they tracked for PTSD? Or is that something that most pediatricians would be tracking in their patients long term?
Yeah, and that's what on discharge is we communicate with their primary care doc. And then most primary care providers are adept at looking at this. But however, they still often may not ask about this. And so if we tell them, great, but if they don't know about it, then they may not ask. So I would say many of these issues go under the surface for many years.
All right, any other questions? All right, give them a couple seconds. I don't see any others. Well, thank you for the presentation. As Doc mentioned, please get back to him with your suggestions. There's his email address again. And then I also created for this session specifically, you'll get the survey, the end of course survey has his email in that as well. So there'll be multiple opportunities coming to you with his email. So for this one, we talked about it and you'll get that as well again. I'm sorry, one more question. How long has PTSD been tracked in kids? How is this relatively new? How long has that been going?
This is new. I was looking at EMS articles just in the last 5 to 10 years. So I think this is just coming up because we're asking the questions. And so it's pretty new. It's been there for a long time that we're now recognizing.
Okay, I think we've run through our questions. Thank you all for attending. Thanks, Doc, for the presentation. Make sure when you get back to him with that information, how we create a child-friendly atmosphere. Again, the email is there, and it's also in the evaluation that's coming to you shortly after this. And for those who were watching earlier ones, if you missed something, video 1 from our first session today is just about done being loaded to YouTube. So our YouTube page is going live. So if that's it, I will say thank you, Dr. Buchholz, for presenting today. And to the rest of you, the next session is tomorrow morning at 8.
You're very welcome and have a nice day. Thank you very much.
Thank you.
Thanks for all you do.